Shall we start now?
Yes, sir. You're quite audible, and we can see the screen as well.
Dear friends, it's with great pleasure that we are commencing today our second session on the same topic, which is catheter hemodynamics. We came up to ventricle and ventricular end diastolic pressures. We entered into pulmonary artery and then the time got over. So we are going to start with pulmonary arteries, but since in today's chat box there are two questions on ventricular end diastolic pressure, we are just going to refresh only that point. Ventricular end diastolic pressure is recorded at the level of R wave, and it is recorded in end expiration in a spontaneous breathing. If the patient is being ventilated, then we need to take it at the peak of inspiration. We need to take the highest value, and the highest value will be in end expiration in spontaneous breathing and end expiration in positive pressure ventilation. So now let us see the two images here. Here we are finding that the basal LV-EDP is varying between 10 to 12 millimeters of mercury in a patient who is having atrial septal defect. And post device closure, it increases almost to 24 millimeters of mercury. So there is a sudden increase in the LV end diastolic pressure, which is defined as restrictive LV physiology. Now, yesterday what I was mentioning was, carefully keep looking at what is the basal left ventricular end diastolic pressure. If the basal left ventricular end diastolic pressure is at the highest level of normal, what is a normal high? The upper limit, it is 12 millimeters of mercury. So if you are touching 12 millimeters of mercury, there is a possibility that there will be further elevation. There are two reasons. Number one, the baseline subset of the patient who may be an adult, a coexistent diabetic, hypertensive, coronary artery disease, or number two, chronically volume unloaded ventricles. In both these conditions, the left ventricular end diastolic pressure in the basal state will be high. Let us assume that we are having a patient who is having a left ventricular end diastolic pressure in only which is 4 or 5 millimeters of mercury. In such a patient, what does that indicate? The average cardiac output is being maintained with the filling of the left ventricle happening at 4 to 5 atmospheres, 4 to 5 millimeters of mercury above the atmospheric pressure. So in which case, this particular patient's cardiac output is being maintained at normal LV filling pressures. Such a patient, after closure of the ASD, is unlikely to have a significant elevation of the LV-EDP to contraindicate a closure. What is the indirect way of assessing this left ventricular end diastolic pressure? We have to put in the catheter into the left ventricle. However, we will start with the diagnostic catheterization by putting the catheter into the right atrium. The left ventricular high end diastolic pressure will reflect on the left atrium, and left atrium will reflect on the right atrium in the presence of large ASD, and so the basal RA mean pressure will be high in patients in whom the basal LVED is 12. If the basal LVED is at the highest level of normal, it is very unlikely RA mean pressure will be 1 or 2 millimeters of mercury. RA mean pressure also will be high. And what is the upper limit of RA normal upper level of RA mean pressure, it is 8 millimeters of mercury. So it will be touching 8 or more than 8. So that is a warning bell that this patient is likely to have either a restrictive left ventricular end diastolic pressures, or the patient has started developing significant pulmonary hypertension, RV hypertrophy, RV non-compliance, and that is getting reflected on the high RA mean pressure. So high RA mean pressure will indicate that either the patient is having a high pulmonary artery pressure with RV non-compliance, or a left ventricle which is not going to tolerate an additional volume overload through the left ventricular inflow because it is already working on higher ventricular filling pressures. So this is what yesterday we were explaining. So now we are going on to pulmonary artery. We started with pulmonary artery. There is a question about what is a rapid filling wave. I'll just briefly go. Rapid filling wave is, in other words, some people will call it dip diastolic pressure. The sudden deflection of the left ventricular pressure going up to the baseline 0, sometimes in a partially underdamped tracing, it might go even less than 0. This particular wave is called as the rapid filling wave, and this rapid filling wave is an index used sometimes in some types of diastolic heart failures. We will come to it when we are talking about restrictive physiologies. Coming to pulmonary artery pressures are systolic of around 15 to 30, mean pressure of around 10 to 20, and diastolic between 4 to 12. An example of a pulmonary artery pressure trace. Here the pulmonary artery pressure is coming close to 50 to 55 millimeters of mercury with diastolic touching very low levels of 5 to 6 millimeters of mercury. This means there is an extremely wide pulse pressure. Possible two contributing reasons. One is severe pulmonary regurgitation and second is peripheral pulmonary artery stenosis bilaterally. So let us come to understanding pulmonary regurgitation. There is another question. In the presence of pulmonary hypertension with normal left ventricular end diastolic pressure, will RA pressure be elevated or decompressed into LA with normal pressure? Every patient who is having either pulmonary hypertension with elevated RV reduced RV compliance due to RV hypertrophy, or left ventricle restrictive LV physiology due to a hidden inability of the left ventricle to tolerate the cardiac output at the given filling pressure, will show up with elevation of the right atrial pressure. Now coming to pulmonary artery pressure trace in moderate pulmonary regurgitation, we already discussed about elevation of the systolic pressure because right ventricular stroke volume increases with each pulmonary regurgitation. So whenever there is an increase in the right ventricular stroke volume, when the pulmonary artery systolic pressure goes higher and higher and the diastolic pressure goes lower and lower, and this creates a situation as if the pulmonary artery pressure trace will look like it is the ventricle, and hence this is called as ventricularization of the pulmonary arterial pressure trace. When there is a very severe pulmonary regurgitation, that results in elevation of the right ventricular end diastolic pressure because the right ventricle begins to decompensate. When the right ventricular end diastolic pressure goes higher and higher, the pressure trace in diastole will start having an upslope like this. That means the tip of the diastole will go to lowest level, but by the time you get the end of diastole, the end diastolic pressure will be high. Actually, what we are showing is a pulmonary artery pressure trace, which is reflecting the right ventricular pressure trace. So this is, in other words, ventricularization of the pulmonary artery pressure, and it is indicating that the right ventricle is failing. So let us now look at the right ventricle itself. The right ventricle will match the pulmonary artery in patients who are having severe pulmonary regurgitation. There will not be much of difference between the pulmonary artery pressure trace and the right ventricular pressure trace. And we explained that after we put in the percutaneous pulmonary valve, what will show up is a diastolic gradient between the pulmonary artery pressure trace and the right ventricular pressure trace. So this diastolic gradient, what we are getting, is the hallmark of a competent pulmonary valve. The advantage of this hemodynamics during a percutaneous pulmonary valve implantation is that instantaneously you will be able to appreciate whether the valve is functioning well or not. On the contrary, this is never achieved in surgery when the surgeon tries to fashion a transannular patch with a monocuspid or bicuspid valve, or he tries to fashion his own RV to PA conduit and test its competency. Because the simultaneous pressure recording of right ventricle and pulmonary artery with a high fidelity transducer is possible only in the cardiac catheterization lab. And so this gives an advantage for us to assess hemodynamics and assess the competence of this pulmonary valve instantaneously. Coming back to pulmonary regurgitation, an example of a very severe pulmonary regurgitation causing elevation of the pulmonary artery systolic pressure and fall of the pulmonary artery diastolic pressure. And in this particular patient, there will be a long period of compensation wherein the pulmonary artery systolic pressure will progressively increase, pulmonary artery diastolic pressure will progressively reduce. However, right ventricular end diastolic pressure will be maintained at the normal levels of less than 8 millimeters of mercury. Thereby, the patient will remain fully compensated. When the right ventricle begins decompensation, right ventricular end diastolic pressure starts rising, touching the levels of 12 millimeters of mercury. Here it is almost touching 16 millimeters of mercury. And this is the time at which it will start reflecting on the right atrium as well. And right atrial pressure is seen elevated here with very tall A waves. And this is a sign of decompensation of a pulmonary regurgitation. So, postoperative tetralogy of Fallot with free pulmonary regurgitation has got a long asymptomatic course with high systolic, low diastolic pulmonary artery pressures and secondary elevation of RV systolic pressure. However, the hemodynamic indicators of deterioration are elevation of right ventricular end diastolic pressure, secondary elevation of right atrial pressure, which will show up with a prominent A waves. If the patient is having significant tricuspid regurgitation due to RV dilatation, then V waves will be higher, and an effect of reverse Bernheim effect on the left ventricle causing secondary LV end diastolic pressure elevation. So these three are the hallmarks of late deterioration of the hemodynamics, and this is the corresponding time when you will get the MRI indicators of right ventricle exceeding 150 ml indexed volumes and the right ventricular ejection fraction falling below 40 to 45%. So these are all the hemodynamic correlators of indicators of a need for pulmonary valve implantation. There is a question: in patients with hypertensive pulmonary regurgitation, there will be a persistent diastolic gradient between RV and PA. Will the trace be similar to post-pulmonary valve implantation? Yes, exactly. In patients who are having hypertensive pulmonary regurgitation, the pulmonary regurgitation is, even if there is a clinically well-audible Graham-Steele murmur, the pulmonary regurgitation is mild to moderate. If there is a very severe pulmonary regurgitation in the setting of very severe pulmonary hypertension, the right ventricle does not tolerate it all, and usually these patients are not alive to the point of seeing a severe pulmonary regurgitation. Most of the patients who are having a hypertensive severe pulmonary regurgitation, if you put in catheters into the pulmonary artery and right ventricle, you will find a large diastolic gradient. It's correct. Now, coming to the next question about post-tetralogy patients, what are the other hemodynamic abnormalities that may be seen? Varying degrees of residual right ventricular outflow tract obstruction, either at the infundibulum or valve, will be seen, wherein RV systolic pressure will be higher than the PA systolic pressure. Varying degrees of peripheral pulmonary artery stenosis will be seen. If the peripheral pulmonary artery stenosis is strictly unilateral, there is a complete redistribution of the blood to the contralateral side, resulting in normalization of the central pulmonary artery pressure. The pulmonary artery in a normal person is filled primarily only in the lower zones. There is a lot of buffer in the upper and mid zones, which normally do not fill at all. In a normal person who is having a normal cardiac output, the working part of the lungs vascularity is primarily confined only to the lower zone. So, whenever the person is having an additional recruitment of more amount of blood entering the pulmonary artery, as in case of physiological reason like pregnancy hyperkinetic state, or physiological conditions like exercise, or pathological condition like atrial septal defect, there will be recruitment of more and more blood vessels, causing upper lobe blood vessels also to be filled. So whenever there is a unilateral peripheral pulmonary artery stenosis, the body tries to redistribute the blood to the contralateral side, and the entire contralateral lung will be utilized, thereby resulting in the pulmonary artery systolic pressure remaining within normal limits. The pulmonary artery systolic pressure increases only when there is elevation of pulmonary artery, only if there is a bilateral peripheral pulmonary artery stenosis. So if you are having a diagnosis of peripheral pulmonary artery stenosis on one side and you put in the catheter into the main pulmonary artery, and if you are finding the main pulmonary artery having a pressure more than 50 or 60 millimeters of mercury, it is a confirmation that the peripheral pulmonary artery stenosis is not unilateral, it is bilateral, it is involving the other side also. There is a caveat to this, which I will come to the next line. Varying degrees of impact of AP collaterals will be present. Whenever the AP collaterals post-tetralogy are still communicating, the pulmonary artery pressure may get elevated proportionate to the size of the AP collaterals. But if the AP collaterals are strictly remaining localized, the localized segments may have segmental pulmonary hypertension or segmental pulmonary vascular disease. This is in the setting of non-communicating AP collateral. But if it is a communicating AP collateral, then the central pulmonary artery pressure will be elevated. Whenever there is a persistent large aortopulmonary collaterals, features of aortic runoff will be present, which are manifested by high aortic systolic pressure and low aortic diastolic pressure. And patients who are having persistent aortopulmonary collaterals to limited segments may have segmental hypoperfusion. Varying degrees of impact due to residual shunts, which may be at atrial level, ventricular level, or arterial level. Arterial level as in persistent PT shunts, persistent AP collaterals, or persistent PDA. Ventricular shunt due to persistence of residual shunts at the level of the patch or at the level of muscular VSD. In unilateral peripheral, I'm going to the question box. In unilateral peripheral pulmonary artery stenosis, how to assess the significance of gradients across the stenotic segment? In unilateral peripheral pulmonary artery stenosis, gradient is not given significance for assessing the severity of stenosis. It is the luminal narrowing and it is the segmental hypoperfusion that you get on a collaborative investigation like a lung perfusion scan or an MRI. If the MRI is showing a ratio between right and left of more than 20% difference, or a lung perfusion scan done with a macro aggregated albumin is showing a difference between right and left of more than 20%, that is significant. And if there is a luminal narrowing of significance in angiographic or in anatomical imaging like a CT scan, that is significant. Pulmonary artery gradients are not given any significance in unilateral pulmonary artery stenosis. Only it works in bilateral peripheral pulmonary artery stenosis. Will pressure in RPA and MPA be the same if LPA stenosis is there? Yes, it will be the same. If suppose there is an additional right pulmonary artery stenosis, then the right pulmonary artery may have gradient. Otherwise, the central main pulmonary artery pressure will be transmitted till the place where you are assessing, as in hilar pulmonary arteries. How will pullback gradient across a peripheral pulmonary artery stenosis? Peripheral pulmonary artery stenosis is going to be associated with very wide pulse pressure in the proximal segment. We are going to come to that in another few slides, and so we will just wait for peripheral pulmonary artery stenosis hemodynamics. So these are the other hemodynamic abnormalities that are seen in post-tetralogy patients. Now going back to the different type of spectrum. So far we were seeing elevation of pulmonary artery systolic pressure. Now this is a low pulmonary artery systolic pressure. So this is a condition of low pulmonary artery blood flow, like tetralogy of Fallot, critical pulmonary stenosis. Whenever you are having a very low pulmonary artery pressures, it is very easy to appreciate the respiratory variations widely, because the normal variation of the intrathoracic pressure to 3 to 4 centimeters of water is transmitted significantly on the traces, and so there will be quite a lot of fluctuations of the pulmonary artery pressure in every patient who is having low pulmonary blood flow. There is another question now. Why don't we get gradient across unilateral branch pulmonary artery stenosis? I just mentioned. The normal lungs has got functioning only primarily in the lower 1/3 of the lung zones. The upper and mid zones are not recruited during normal physiological circulation. We get recruitment of the upper and mid zone only when we physiologically increase the cardiac output, as in pregnancy or in exercise. Otherwise, in pathological condition like atrial septal defect, it will get recruited. In normal conditions, the lungs that are recruited is confined to the lower zones only. This is one of the reasons why primarily you will find vascularity confined in the chest X-ray to the lower zone. Whenever we see vascularity in the upper zone, then we call it either plethora, or if it is a venous hypertension, that is a sign of cephalization. So the normal pulmonary arteries fill primarily in the lower zone only. So there is a lot of opportunity for the pulmonary circulation to redistribute the blood from stenotic side to the non-stenotic side. Let us assume RPA is narrowed. Blood will be distributed into the LPA, thereby LPA will not, the LPA will be able to take the entire QP, so the central pulmonary artery pressures do not increase. So the gradient between the central main pulmonary artery and the hilar pulmonary artery of the stenotic side will be minimal only. Do every unilateral pulmonary stenosis need a CT, MRI or perfusion studies? In order to find out the significance of hypoperfusion of one of the side, it is important to do an MRI or a perfusion study. This is a functional study. CT or angiography is an anatomical study. An anatomical study will tell what is the severity of luminal narrowing. A functional study will tell the ratio of perfusion between right and the left side. Now, very often, if suppose you don't want to do any of these things, one of the indirect way of assessing the severity of pulmonary stenosis by a simple echocardiogram will be, if there is a very tight RPA origin stenosis, you look at the pulmonary venous return on both the right pulmonary vein and the left pulmonary vein, you will find abundance of venous return on the left side and lack of venous return on the right side, and that will be a rough correlate about how much of redistribution is happening. So we will be looking at the severity of an unilateral pulmonary artery stenosis during cardiac catheterization, not by absolute gradient numbers. Now coming to the pulmonary artery pressure, whenever the pulmonary artery pressure is low, it is very easy to see the respiratory variations. In patients with pulmonary atresia, to assess the pulmonary artery pressure, we may have to resort to pulmonary vein wedge tracings, which will reflect the pulmonary artery pressure, of course, with the same degree of respiratory variations. Glenn flows, when we are checking the pressures, will primarily remain non-pulsatile if there is no antegrade flow, but will become pulsatile if there is a persistent antegrade flow, or there is a moderate sized PDA or an AP collateral that is flowing into the Glenn circuit. Very, very rarely, the left atrial pressure may reflect on the Glenn circuit if there is a severe mitral regurgitation. A tall V wave of a mitral regurgitation may reflect onto the Glenn trace. Pulmonary vein wedge pressure is taken as a correlate of pulmonary arterial pressures in patients where you are not able to enter the pulmonary artery directly. Coming to pulmonary arterial hypertension, which is actually a very important topic because quite a lot of cardiac catheterizations are performed for pulmonary arterial hypertension. And so we are going to take a little bit of time in analyzing pulmonary arterial hypertension. Mild PAH is defined as a mean pressure of 20 to 35 millimeters of mercury. Moderate is 35 to 50 millimeters of mercury. As I mentioned, some use 45 millimeters of mercury, and severe is any PA pressure which is more than mean of 45 or 50 millimeters of mercury. So this is an example of a pulmonary arterial hypertension patient with a mean pressure of around 43 millimeters of mercury. So there is moderate pulmonary arterial hypertension with PA systolic of around 72 millimeters of mercury. Again, it is a moderate pulmonary arterial hypertension. While a lot of importance is being given for the mean pressures, we need to remember that mean pressure is actually an electronic average of the machine for the area under the curve that is below this pressure trace. Now coming to pulmonary arterial hypertension in congenital heart disease, we are going to be discussing this particular topic in detail at depth in the next session, wherein we are going to see on oximetry calculations. However, just one slide about how pulmonary arterial hypertension is classified in congenital heart disease. We know that one extreme will be Eisenmenger syndrome, where already the shunt has reversed and there is a right reduction. There is a second group where there is a large amount of still persistent left-right shunt in patients who are vulnerable to get hyperkinetic pulmonary hypertension as an ASD of more than 2 centimeters and a VSD of more than 1 centimeter. But the hemodynamics are showing borderline operability. The third group is patients who are having pulmonary hypertension with insignificant lesion, less than 2 centimeter ASD or less than 1 centimeter VSD, but with severe pulmonary hypertension, where very often this is considered to be an idiopathic pulmonary hypertension with coexistent ASD or VSD. And the last group is operated shunt lesions who are having persistent or recurrence of PAH. When we record aorta and pulmonary artery pressure simultaneously in a patient who is having a large shunt, this is an example of a PDA patient who is having a large shunt. Look at the aortic pressure. There is a high systolic pressure, equal diastolic pressure. Pulmonary artery pressure is not showing such a wide trace. What is the reason behind this? Now, before coming to the reason behind this, let us go into how we quantify an echocardiographic shunt in an ASD or a VSD. In an ASD or VSD, the QS is calculated by the aortic VTI into aortic cross-sectional area, and QP is pulmonary VTI into pulmonary cross-sectional area. So an ASD or a VSD with hyperkinetic PAH will have a higher QP. The higher QP will get reflected as a higher pulmonary VTI and a higher pulmonary cross-sectional area. But exactly it is the opposite in pulmonary, in PDA, where it is the reverse. The QS is actually at the level of pulmonary VTI and pulmonary cross-sectional area, and QP is at the level of aortic VTI and aortic cross-sectional area. I am sure all of you clearly understand this. So now look at the hemodynamics. The QP by QS is high in a PDA with hyperkinetic PAH. So what does that mean? LV stroke volume is higher than the RV stroke volume in a patient with PDA and hyperkinetic PAH. Higher LV stroke volume will cause a higher LV systolic pressure and higher aortic systolic pressure. So aortic systolic pressure will be higher than pulmonary artery systolic pressure in large hyperkinetic PAH associated with a large PDA. So aortic pressure being higher than the pulmonary artery pressure in a large PDA with large hyperkinetic PAH is the rule. That is one of the reasons why a clinical correlate in a patient with a large PDA, you will have a persistence of systolic murmur. There will not be a continuous murmur. Diastolic murmur will go silent. So there is, in other words, equalization of diastolic pressure. So this is the hallmark of PDA. So how do you differentiate between PDA and VSD? If you are having a patient who is having an extremely large PDA, the aortic and pulmonary artery pressure will become almost similar. But you start giving oxygen. Oxygen is now causing a fall in the pulmonary vascular resistance due to relief of the pulmonary vasospasm. And this is resulting in higher QP. Higher QP causes better filling of the left ventricle, better left ventricular stroke volume. Higher left ventricular stroke volume results in higher left ventricular systolic pressure and higher aortic pressure. And so the higher aortic pressure will now show up as aorta going higher than the pulmonary artery, but diastolic pressure will remain equal. So in other words, diastolic pressure equalization is the rule in a PDA. On the contrary, in a ventricular septal defect, ventricular septal defects, again we are having a similar situation, a large ventricular septal defect wherein there is an equalization of aortic and PA pressures. You start giving oxygen, the oxygen causes a fall in the pulmonary vascular resistance due to pulmonary vasodilatation. The fall in the pulmonary vascular resistance results in fall in the pulmonary artery diastolic pressure, because when the semilunar valves are closed, there is a continued runoff from the pulmonary artery into the pulmonary capillary bed. So the pulmonary artery diastolic pressure progressively keeps falling down and down and down. So there is a systolic equalization but diastolic separation. So this diastolic separation will result in fall in the pulmonary artery mean pressure. In the previous case, when there is a PDA with two pressure tracings, again the PA mean pressure falls below the aortic mean because aortic systolic pressure has got increased. But in VSD, the pulmonary artery diastolic pressure got lower, and so the PA mean pressure again reduced. So to check the operability, in both cases the pulmonary artery mean pressure will fall below the aortic mean pressure, thereby indicating that this patient is operable. Now there is a question, why the reverse of PDA for QP by QS, can you explain? Basically, this is the basics of echocardiography. When you have an ASD or a VSD, if you have a left to right shunt, the left to right shunt carries the blood that is passing through the shunt into the right ventricle, and the right ventricle pumps it into the pulmonary artery. The pulmonary valve annulus carries not only the normal cardiac output but also this additional shunt, and hence QP is determined at the pulmonary valve annulus with pulmonary annular VTI multiplied by pulmonary annular cross-sectional area. In PDA, since the left to right shunt is happening at great arterial level, the higher QP is transmitted through the left ventricle into the ascending aorta. So ascending aorta carries a large amount of blood. That is the reason why there is a functional aortic stenosis in patients with large PDA with high pulmonary blood flows. If there is systolic equalization in a large PDA as well as diastolic, does it mean obstructive PVR more likely inoperable? You have to use the vasodilator strategies in order to find out whether the aortic systolic will go up in a PDA, in a large PDA. By definition, if there is an extremely large PDA, the aorta is directly in communication to pulmonary artery with a large lumen, and so the aortic systolic pressure and pulmonary artery systolic pressure will be the same. During diastole, even after closure of the semilunar valves, the aorta and pulmonary artery are still in continuity with each other, so diastolic pressures are the same. So in a large PDA, very, very large PDA, ideally speaking, aortic pressure and pulmonary artery pressure will be the same. But if you are inducing pulmonary vasodilatation with a pulmonary vasodilators, which can be either oxygen or nitric oxide, you are going to have elevation of the aortic systolic pressure caused by a higher aortic stroke volume. is it necessary to consider when mean pressure is more than 50 tells that systolic will be more than 75? I'm not able to understand the question. In patients with large VSD and large PDA, will systemic PA, systolic, diastolic pressure will be the same? Yes, that is what I was mentioning. Whenever there is a patient with a large VSD or a large PDA, extremely large VSD or an extremely large PDA, the pressure trace will be like this. Now going to the next step. Coming to the core topic of pulmonary hypertension. Pulmonary hypertension is one of the common causes of performing a cardiac catheterization in today's laboratory, and hence we need to know why we will do a cardiac catheterization in pulmonary hypertension. Diagnosis. Primarily, diagnosis of pulmonary hypertension is made in the cardiac catheterization lab, given the fallacies of echocardiogram. So still the guidelines say cardiac catheterization is the gold standard for diagnosis. Differentiating different types of PAH, we will come to it in the next slide. Vasoreactivity testing, we will come. Prognostication of patients with PAH. There are certain prognostic indicators of PAH in the cardiac catheterization. Selection of patients for interventions like balloon atrial septostomy or POTS. Coming to diagnosis. Still, cardiac catheterization remains the gold standard for diagnosis because of fallacies of echocardiogram by RV systolic pressure or RV dilatation, these being late findings. So if you are having a patient with early onset pulmonary hypertension, wherein the pulmonary artery mean pressure is only 30-40 millimeters of mercury, you will not be able to get this particular patient diagnosed on simple echocardiography, and that is one of the reasons why many of the patients, by the time we diagnose idiopathic pulmonary hypertension, these patients are already in the very severe pulmonary hypertension group, and most of them have already started failing their right ventricle. That's one of the reasons why diagnosis of pulmonary hypertension still today is cardiac catheterization is considered the gold standard for diagnosis. The PA mean pressure should be more than 25 millimeters of mercury, which is now revised recently to 20 millimeters of mercury. Pulmonary capillary wedge pressure should be less than 15 millimeters of mercury in idiopathic pulmonary arterial hypertension, and PVRI should be more than 3 Wood units. And the additional information that we are going to get will be cardiac output and vasoreactivity testing and identifying a hidden shunt. Now there is a question, why there is diastolic separation in VSD and systolic separation in large PDA? I just now explained that. Okay. Probably, I think once we share this video, then again you'll get to know it. Is my audio very clear or audio is poor?
Sir, it's quite clear.
Okay, thank you. I'm going slow, but suppose the same topic is again coming up, like probably we will wait for that the questions will be clarified when this video is recirculated. Now coming to differentiation of various types of PAH, the basic difference between pre-capillary and post-capillary pulmonary hypertension. Post-capillary pulmonary hypertension is not called pulmonary arterial hypertension, it is pulmonary hypertension, wherein the PA wedge pressure is equal to PA diastolic pressure. Whereas in pre-capillary pulmonary hypertension, which is actually called as pulmonary arterial hypertension, the pulmonary artery wedge pressure is lower than the PA diastolic pressure. So this is an example of pulmonary capillary wedge pressure mean of 21 millimeters of mercury. You are pulling the catheter into the pulmonary artery. The pulmonary artery diastolic pressure is also 21 millimeters of mercury. The PA systolic pressure is 35. The mean pressure is more than 20. So this is pulmonary hypertension, but this is mild post-capillary pulmonary hypertension. Now, one exception for that previous rule is among the patients who are included in the pulmonary arterial hypertension, which is the type 1 group, one of the exception to this rule is pulmonary veno-occlusive disease, where the pulmonary artery wedge pressure can be lower than the PA diastolic pressure. How to differentiate this particular form from the other forms of pulmonary hypertension? In this particular patient, you may be having a pulmonary artery wedge pressure which is high, but the LA pressure will be normal. The clinical indicators will be clinically multiple crackles, chest X-ray showing interstitial lines, mediastinal lymphadenopathy, low carbon monoxide diffusion, and low saturations. Otherwise, all patients with pulmonary arterial hypertension will have PA diastolic pressure higher than the pulmonary capillary wedge pressure. Now coming to differentiation between the different types of pulmonary hypertension, I am showing two examples. This is idiopathic pulmonary hypertension. This is thromboembolic pulmonary arterial hypertension. Carefully look at the trace. The systolic pressure is sort of matching between the two, but the diastolic pressure is significantly high in idiopathic pulmonary arterial hypertension and reasonably lower in chronic thromboembolic pulmonary hypertension. What is the difference between the two? In chronic thromboembolic pulmonary hypertension, it is basically due to occlusion of the pulmonary arteries at various segments, especially if it is in the hilar or immediate post-hilar pulmonary artery. The high pressure is in the proximal segment. The proximal segment is the main pulmonary artery. So at that time, the main pulmonary artery behaves as if it is a peripheral pulmonary artery stenosis, because pulmonary artery is an elastic vessel with a high capacitance, and so when there is a severe peripheral pulmonary artery stenosis, the pulmonary artery diastolic pressure goes extremely low. I will show an example of a severe peripheral pulmonary artery stenosis. There is a patient who is having a tight RPA and LPA origin stenosis. There is a simultaneous catheter, one in the right ventricle. The right ventricle is recording 135 millimeters of mercury, indicating severely elevated RV systolic pressures. The right pulmonary artery pressure is hardly about 30 to 35 millimeters of mercury systolic, and when you pull from RPA to the main pulmonary artery shoots to a very high level of 135, and the main pulmonary artery diastolic pressure is very low, going to 20 millimeters of mercury. So the pulmonary artery pressure proximal to the bilateral peripheral pulmonary artery stenosis is also ventricularized, like severe pulmonary regurgitation. So now coming to the same scenario in idiopathic PAH versus chronic thromboembolic PAH. In chronic thromboembolic PAH, yes, condition is similar to peripheral pulmonary artery stenosis. So the PA diastolic and the PA diastolic pressure goes lower. Now it doesn't happen in idiopathic pulmonary artery. The first one is chronic thromboembolic pulmonary hypertension. The second one is idiopathic pulmonary arterial hypertension. What happens in idiopathic pulmonary arterial hypertension? In diastole, when the semilunar valve is closed, still the vascular resistance is so high that there is no runoff from the central pulmonary artery into the periphery, thereby resulting in a second hump on the PA's pressures. And so the PA mean pressure as well as the PA diastolic pressure remains significantly high. In chronic thromboembolic PAH, which is similar to peripheral pulmonary artery stenosis, the PA diastolic pressure is very low. Now, immediately people might think, if this is the case, this is very good to have chronic thromboembolic PAH and very bad to have idiopathic PAH. We need to differentiate between the two. RV systolic pressure is similar in both the conditions. Similar degree of RV dysfunction will happen because RV dysfunction is proportionate to severity of the pulmonary hypertension, rapidity of rise of PA pressures, and the RV adaptation. And so in both the patients, RV dysfunction may be similar. Because the RV dysfunction is common, similar degrees of symptoms due to RA pressure elevation and fall in the cardiac output will happen between the two. The only difference will be PA diastolic pressure will be low and the PA mean pressure will be low. So if you are using an echocardiographic index, the PA systolic pressure by RVSP measured by TRjet will be quite high, However, you will not be able to get a very, very high level of PA diastolic pressure as in the case of idiopathic PAH when you are analyzing the pulmonary regurgitation Doppler trace. The pulmonary vascular resistance will be high in both the conditions, but for the same degree of cardiac output, the chronic thromboembolic pulmonary arterial hypertension will have a lower PVR because most of the time the chronic thromboembolic pulmonary arterial hypertension will have lower pulmonary artery mean and a lower pulmonary artery diastolic compared to another idiopathic pulmonary arterial hypertension. The next reason why we will be doing a cardiac catheterization will be vasoreactive testing, and we all know that we will find out a distinctly different prognostic group by doing this vasoreactive testing, wherein 5 to 8% of patients with idiopathic PAH may be vasoreactive testing responders, and these patients respond to calcium channel blocker. Types of agent that are used, initial recommendations were inhaled nitric oxide starting at 10 going up to 20 parts per million, or using epoprostenol at a dose of 1 to 2 nanogram per kg per minute progressively increasing, or using adenosine at 50 microgram per kg per minute and progressively increasing to 300 microgram per kg per minute. Later, it was observed that much more simpler agents like nebulized iloprost, intravenous sildenafil bolus, intravenous treprostinil bolus can also give similar comparable results, but all these are anecdotal reports by individual authors. In fact, in the literature you will also find inhaled nitroglycerin and inhaled milrinone being used for vasoreactive testing. So basic principle is we give a particular vasoreactive agent, and still the first three agents are what are primarily recommended for vasoreactive testing in the cardiac catheterization laboratory. There are different criteria given for idiopathic pulmonary hypertension and congenital heart disease shunt. So we will concentrate on idiopathic PAH now. There are a couple of questions. Adenosine method of administration. Adenosine method of administration is not same like supraventricular tachycardia. In supraventricular tachycardia, we give a urgent bolus, whereas here it is an infusion. It is given more like how you are giving for adenosine stress myocardial perfusion scan imaging, or how you are using for coronary flow coronary flow reserve testing. It is given as a sustained infusion. Adenosine is not given as a bolus. The second question is, do you regularly use calcium channel blocker responsiveness in every case of pulmonary hypertension? Ideally speaking, the purpose of doing a cardiac catheterization for an idiopathic PAH is number one, confirmation, and number two, to check the responsiveness for vasoreactivity, because this is going to identify a distinctly different prognostic group compared to the regular idiopathic PAH. So one of these three agents are recommended. 100% oxygen is not recommended. Criteria for responder is 10 millimeters mercury reduction in pulmonary artery mean pressure with an absolute PA mean pressure going less than 40 and a preserved cardiac output. And what was added later was 20% reduction in the pulmonary artery mean and 20% reduction in the pulmonary vascular resistance. For calculation of pulmonary vascular resistance, we need to know the cardiac output, and cardiac output is recommended to be taken by thermodilution and not by fixed principle. Extrapolation of vasodilator responsiveness, which we will be seeing in the next topic. I'm just giving only the points here. 20% reduction in pulmonary vascular resistance coming to an absolute value of less than 6 Wood units, and 20% reduction in PVR to SVR ratio coming to an absolute value of less than 0.3. There is a question, calcium channel blockers always will be responders. We should not use the word calcium channel blocker responder. It is vasoreactive responder who are subsequently treated with calcium channel blockers. And these patients tend to have a good prognosis. Some of them do lose their reactivity over a period of time, and hence These patients should get a restudy periodically to find out whether they continue to be vasoreactive responders or they are moving into non-responder group. And if they move into non-responder group, they need to be given specific pulmonary vasodilators. If a patient is having severe pulmonary arterial hypertension and right heart failure post-diuretic stabilized and taken for right heart catheterization, PA mean pressure is only 28 millimeters of mercury. Should we still do vasoreactivity? Basically, the PA mean pressure, the criteria that are given for finding out a vasoreactivity is 10 millimeters of mercury fall in the PA pressures and an absolute PA mean pressure coming to less than 40. If a patient is having a severe pulmonary arterial hypertension with a right heart failure who just got stabilized with only medical management, this is an indicator of the patient having pulmonary arterial hypertension due to some transient pathology, which can be something like hypothyroidism, bronchopneumonia, sleep apnea syndrome, some pathology that was correctable and which got corrected. The pathology of idiopathic pulmonary arterial hypertension with severe pulmonary arterial hypertension and right heart failure is very unlikely to come down to 28 millimeters of mercury. Now coming to prognostication, the next reason what we get an information is prognostication. The pulmonary artery systolic, diastolic and mean pressure are not prognostic. This vary from person to person. It is the amount of impact of this high pulmonary artery pressure on the right ventricle and right atrium, that is what is prognostic. So an elevated RA pressure is prognostic. A low cardiac output and an indirect correlate of cardiac output as mixed venous oxygen saturation being low is prognostic. Higher RV end diastolic pressure and higher LV end diastolic pressure due to reverse Bain-Heme effect is prognostic. A higher and higher pulmonary vascular resistance is prognostic, not pulmonary artery systolic, diastolic and mean pressures. Selection of patients for balloon atrial septostomy. Now, since the era of mechanical treatment of pulmonary hypertension is becoming more and more popular, we need to know in which sort of patients we will be doing balloon atrial septostomy, or in other words, right atrial decompression. Patients who are having syncope, that means patients who are unable to increase their cardiac output occasionally. Number two, patients who are having severe right ventricular failure, that means the right ventricle is dilated beyond a point that the Frank-Starling's law is no longer acting and the RV dilatation has gone on to the descending limb of the Frank-Starling's curve. Failure of basic medical treatment. And the extended indication will be either a bridge to transplantation or in places where there is no transplantation as a destination therapy for transplantation. The patient should be included only if they satisfy this criteria. So if they don't satisfy this criteria, these are exclusions. RA pressure should be less than 20 millimeters of mercury. Left ventricular end diastolic pressure should be less than 18 millimeters of mercury. PVRI should be less than 55 Wood units and saturation should be, sorry, this is not less, this is more than 90%. What is the basic reason? If your RA pressure is more than 20 millimeters of mercury, there will be abundant right to left shunt leading to very profound hypoxia, and these patients can have procedural morbidity and mortality. If the basic reason for doing a balloon atrial septostomy is to improve the left ventricular preload, so if the left ventricle is already working at a very high filling pressure, close to 18 millimeters of mercury, further increase of the preload is not going to be tolerated by the left ventricle. If the pulmonary vascular resistance is unphysiologically high, more than 55 Wood units, these patients will not tolerate this procedure. If the pulse oximeter saturation is already less than 90, these patients, the additional hypoxia that is going to happen will be so profound that these patients will not be tolerate that hypoxia. And even when we are doing a graded balloon dilatation, stop when the saturation reduces more than 10%, because more than 10% drop in the saturation is not going to be tolerated by patients during balloon atrial septostomy. Now, this is very important to know because Balloon atrial septostomy has been tested on various studies and a large meta-analysis, a group study done by Sandoval over a patient group of close to 380 patients has arrived at these numbers. And so these numbers are now given as a standard guideline for doing balloon atrial septostomy. Selection criteria for part shunt. Unlike balloon atrial septostomy, which has got many reports, as I mentioned, Sandoval's meta-analysis and basic guideline-based recommendation. Guidelines specifically state those 4 guidelines that I mentioned. Part shunt is primarily surgical. There is no definite hemodynamic criteria. Most surgical indications are not based out of hemodynamic criteria. I already mentioned. Many times during surgery, you will not be able to accurately assess hemodynamics with high fidelity transducers. I'm going to show an example of a part shunt. Physiologically, if you want to do a part shunt, the pulmonary artery pressure needs to be suprasystemic in systole, in diastole, in mean. This is an example of a pulmonary artery pressure. Systolic, diastolic and mean all are higher than the aortic, systolic, diastolic and mean. Aortic pulse pressure is extremely low because of low cardiac output. Reason for the low cardiac output is extremely low left ventricular filling caused by severe pulmonary arterial hypertension, and this pulmonary arterial hypertension is not allowing the cardiac output to get transmitted on to the left side of the heart. So the patient is having severe suprasystemic pulmonary artery hypertension. So this should be present even at rest. The reason is, if you are doing a part shunt in a patient who is having a pulmonary artery pressure which is comparable to aortic pressure, and at times the pulmonary artery pressure is lower than the aortic pressure, these patients will have a left to right shunt which will have no advantage, rather it will create more problem for the patient. The RV systolic pressure after a part shunt improves. The PA systolic pressure now comes down. The PA diastolic and the aortic diastolic become the same. So this is a successful part shunt's hemodynamic. Very carefully analyze the trace. I'm telling that this is a successful part shunt. But you are observing that the PA systolic pressure is still high. We need to understand this very clearly. After you perform a part shunt, you are diverting the blood from pulmonary artery into the descending thoracic aorta, and the quantum of blood that is coming out from the LA and LV is still very low. LV stroke volume, LV continues to be underfilled, LV preload is still low in a patient after part shunt. You are improving the aortic perfusion by perfusing from the pulmonary artery to aorta, but the pulmonary venous return, which is causing the LA and LV filling, is still low. So the left ventricular stroke volume still remains low. Left ventricular systolic pressure and the aortic systolic pressure still remains low. On the contrary, PA pressures will be higher because the quantum of blood that is going through the pulmonary valve is much higher than the quantum of blood that is going through the aortic valve. So exactly similar to what I told in a patient who is having a large PDA with no pulmonary vascular resistance, where there is a diastolic equalization between the PA and aorta, but in systole aortic pressure is much higher. The reason why in aorta the systolic pressure is much higher is because of higher LV stroke volume. In post-part shunt, LV stroke volume is still low. LV is still underfilled. LV stroke volume being low results in LV systolic pressure being low and aortic systolic pressure being low. post-part shunt pulmonary artery systolic pressure hence will continue to be higher than the aortic systolic pressure, but the magnitude of reduction from PA from the preoperative level here to this is PA pressure is much higher to this new level, which is PA pressure is much lower, will result in an improvement in the RV systolic pressure. So the RV pressure, RV systolic contractility will improve. However, we need to understand that the LV filling will continue to be reduced. In other words, LV preload deprivation is still continuing. So we need to understand these two very clearly. Balloon atrial septostomy results in an underfilled LA and underfilled LV to get a better LV preload. Balloon atrial septostomy avoids syncope by improving LV preload and improving LV stroke volume, which maintains aortic perfusion. When the right ventricle is getting decompressed, if the right ventricle is working at the descending limb of the Frank-Stallings law, the balloon atrial septostomy results in decompression of the right ventricle, which pushes the right ventricle from the descending limb to the plateau portion, or sometimes the ascending portion, thereby improving the RV systolic function. So going back to the primary three indications of balloon atrial septostomy, patient who are having exercise-induced syncope. Number two, patients who are having right ventricular failure. Number three, patients who have failed maximum medical therapy. So in right ventricular failure, you are pushing the right ventricle from the descending limb of the Frank-Stallings law to the plateau portion of the Frank-Stallings law. In part shunt, it reduces the suprasystemic PA pressure to near systemic PA pressure. The advantage of part shunt is that it avoids brain hypoxia. But we need to understand that the left ventricle preload further reduces. The PA pressure, the PA decompresses into the descending thoracic aorta. So the QP, that is the quantum of blood that is going through the pulmonary capillary circulation and returning to the pulmonary veins and filling the LA and LV, will further reduce, which results in reduction in the LV stroke volume. This is one of the reasons why 10 to 20% of the patient may have a sudden precipitation of low cardiac output following a part shunt, and in the limited number of studies that have performed surgical part shunt, uniformly there is a 10 to 20% peri-procedural mortality caused by this acute left ventricular preload deprivation. Now when we ask the same question on balloon atrial septostomy, balloon atrial septostomy's mortality also has been quantified in Sandoval's analysis of more than 380 patients. The acute procedural mortality for a graded balloon dilatation balloon atrial septostomy in the hospital varies between 7 to 8%. And if you include a 30-day mortality for a patient for a static balloon, for a staged balloon dilatation, balloon atrial septostomy, it goes to around 20%. Basically, this represents the sickness of the subset. What is the disadvantage? There are a couple of questions. Would the systolic pressure be different in ascending and descending aorta post-part shunt? No, ascending aorta, descending, the entire central arterial pressure tree from large arteries to medium arteries, all will uniformly be the same. Whatever pressure we are getting in the ascending aorta will be the same pressure in radial artery, will be the same pressure in dorsalis peris artery. So pressures will be the same across the entire vascular tree. The amount of blood that is flowing into the aorta is actually higher after a part shunt. Your aortic pressures are maintained after a part shunt. Part shunt keeps a higher aortic pressure head. It facilitates by preventing a brain hypoxia, which is the feature of balloon atrial septostomy. However, LV is preload deprived. LV will not have a forward cardiac output. In patients who are extremely advanced in pulmonary hypertension, this lack of LV preload will result in complete absence of a cardiac output. The quantum of blood that is going through the pulmonary capillary circulation and returning to the pulmonary vein will enormously reduce. Most of the QP that is coming out from the pulmonary artery, like a ductus in a fetus, will completely go into the descending thoracic aorta, resulting in total deprivation of pulmonary capillary circulation. So the left atrial and left ventricular return will completely be compromised. And we need to have some amount of blood going through the pulmonary capillaries and returning to the left atrium and left ventricle in order to maintain systemic oxygenation. So exactly like a fetal circulation, you will be directing only 10 to 20% into the pulmonary capillary bed and diverting most of the blood from the pulmonary artery into the aorta through a large portion, which will result in enormous LV preload deprivation, and this will cause terrific reduction of left ventricular stroke volume. Now coming back to, we have completed the chapter on pulmonary arterial hypertension and we are going to aortic pressure. Aortic pressure depends on multiple factors like stroke volume. Higher the stroke volume, higher the aortic pressure. As we saw, aortic regurgitation or a PDA will have higher aortic systolic pressure. Ejection velocity. The more forcible the ejection, the more higher will be the LV systolic pressure, and this is the reason why in patients who are having LV dysfunction, there will be decapitation of the aortic systolic pressures. Intravascular volume is obvious. Vascular compliance is very important. In the elderly patients who are having low vascular compliance due to arteriosclerosis, enormous elevation of arterial pressure will be there, and obviously systemic vascular resistance. When we pull back from the left ventricle to the aorta, there should not be any gradient between LV to aorta, and very often in clinical fluid-filled transducer system you will find this. LV pressure is around 125 and the aortic pressure is 115, and many of the fellows might give this result as 125 and 115. You need to remember that in fluid-filled catheter transducers, there is a small overshoot at the beginning of the LV systole, and that is what is causing the LV to go to 125, and it is actually, there is no difference between LV systolic pressure and the aortic systolic pressure, and there is no gradient in physiological state. We already discussed about how to measure the like the zeroing of the transducer. Now looking at this pressure trace, ascending aorta has got a percussion wave and the tidal wave. The tidal wave is actually the reflected wave. Percussion wave is the impact wave. The impact wave is the LV ejection into the aorta. Tidal wave is the reflected wave from the peripheries, from all the branch points. Then comes the dicrotic notch, which corresponds to the closure point of the aortic valve, and there is a dicrotic wave. As you move from central aorta to peripheral aorta, since the reflected waves come earlier and it is higher in intensity, there is a peripheral systolic amplification, and you will find that there is an early peaking of the aortic systolic pressure in peripheral arteries with a higher systolic pressure. Whenever the dicrotic, post-dicrotic notch, there is a prominent dicrotic wave. This is something similar to the idiopathic pulmonary arterial pressure trace that I showed a few slides before. In diastole also, the high systemic vascular resistance will have a higher diastolic pressure. This is due to high systemic vascular resistance, and this pulse is called as dicrotic pulse. It is an indicator of extremely low cardiac output and a compensatory severe sympathetic vasospasm and a high systemic vascular resistance. It is found in patients wherever they are sick with very, very high vascular resistance. Bispherian pulse is otherwise called as double peaking pulse. The term bispherians means double peaking, and this is two peaks happening in systole, characteristically seen in aortic regurgitation or combinations of aortic stenosis and aortic regurgitation, wherein A high left ventricular stroke volume results in a very high initial systolic pressure. And then there is a continued high amount of blood that is being pushed across from the LV into the aorta, which sends a forward moving suction wave, which is actually something like a Venturi effect. And this Venturi effect will cause a fall in the mid systolic pressure. And subsequently it is maintained higher. So Bispherians pulse in aortic regurgitation is due to a forward moving suction wave or a Venturi effect that is running due to a huge amount of blood that is being ejected from the left ventricle. This is also seen in hypertrophic cardiomyopathy, and we will be discussing it in hypertrophic cardiomyopathy. Alternance is a feature wherein every alternate beat is weaker and stronger. The reason is because of alteration in the intracellular calcium influx. So one beat is very powerful. The calcium that has been extruded from the endoplasmic reticulum into the sarcolemma is not being taken up adequately, and hence the next cardiac cycle does not have an adequate amount of calcium influx, and that is resulting in a lower contractility. However, this has resulted in preservation of the myocardial kinetics, so that the next one will be again very powerful due to higher calcium influx. So pulsus alternans is a feature of extremely weak ventricles, as you see in cardiomyopathies. Mechanism of dicrotic pulse in severe congestive heart failure or in severe low cardiac output state is because of high systemic vascular resistance, which keeps the diastolic pressure very high. It's a very high systemic vascular resistance. Pulsus alternans needs to be differentiated from pulsus bigemini, which is caused by ventricular bigemini, and this is clinically differentiated by intermittent cannon waves on the jugular venous pulsations on clinical examination. When you are looking at a left ventricle to ascending aortic pressure trace, you have to identify, is there a systolic gradient between the LV and aorta? And if there is a gradient between LV and aorta, that means this is aortic stenosis. Severe aortic stenosis in cardiac catheterization is defined as a gradient peak to peak of more than 50 millimeters of mercury. So this is the ascending aortic trace, and an LV trace, a gradient of more than 50 millimeters of mercury is severe aortic stenosis. We need to understand certain concepts. What you record in echocardiography is peak instantaneous gradient. At one particular given instant, what is the peak gradient? That is peak instantaneous gradient, and peak instantaneous gradient on echocardiography of more than 64 millimeters of mercury is considered severe aortic stenosis. What we get in cardiac catheterization is peak to peak gradient. Peak to peak gradient of more than 50 millimeters of mercury is actually called severe aortic stenosis for hemodynamic indications. And in this particular patient, it is 40 millimeters of mercury. You can see here LV pressure peak is 130, aortic pressure peak is 90. So there is 40 millimeters of mercury. This is peak to peak gradient, and this is peak instantaneous gradient. Mean gradient is the area under the curve. Area under the curve is recorded both in echocardiography as well as in cardiac catheterization, and the area under the curve is the mean aortic gradient. Whenever we are recording the aortic stenosis hemodynamics, we need to find out whether the pigtail is in the LV and the second aortic catheter is in the femoral artery or in the ascending aorta. If it is in the femoral artery, there is a phase delay between the femoral artery and the left ventricle, and there is a peripheral systolic amplification of the femoral artery, and so the gradient will be slightly different. Because of the phase delay between the femoral artery pressure and the left ventricular pressure, a much higher mean gradient will be recorded. We need to be careful in assessing the hemodynamics in such patients. Aortic stenosis gradient is extremely important. Lots and lots of guidelines for adult aortic stenosis management is based on peak gradient of more than 64 and mean gradient of more than 40, with aortic valve area of less than 1.0 and indexed aortic value of less than 0.6 square centimeters. We need to understand aortic stenosis gradient is completely flow dependent. So if you are having LV dysfunction, there is low cardiac output and low stroke volume. Low stroke volume will result in lower gradient for the same aortic stenosis severity. The aortic stenosis is giving the resistance. So the aortic valve resistance is equal to pressure gradient by flow across the aortic valve. And so for the same degree of aortic valve resistance, if the flow is low, the pressure gradient will be low. So this comes to the concept of what is low flow, low gradient aortic stenosis. Whenever there is a severe left ventricular systolic dysfunction with an aortic valve area of less than 1.0, your ejection fraction will be lower than 40. Mean pressure gradient may not be 40, it may be 30 or 40, and still it may be severe aortic stenosis. In such patients, if you challenge them with dobutamine, and the dobutamine increases the effective orifice area to more than 1 square centimeter, this is pseudo-severe aortic stenosis. If the dobutamine increases the gradient to more than 40, and the valve area still remains at less than 1 square centimeter, it is true severe aortic stenosis. There will be a small number of people whose left ventricle will be having no response to dobutamine. And if such patients, the ejection fraction does not increase by 20% from the baseline, they are called as low contractile reserve. So this is a low gradient, low ejection fraction patient. So this is low gradient, low ejection fraction. The gradient is less than 30, but the valve area by continuity equation is 0.6. Is it severe or not? You give dobutamine. Dobutamine results in improvement of the LV contractility. LV ejection fraction becomes 45%. Gradient increases from less than 30 to 50 millimeters of mercury. The aortic pressure does not increase so much like the increase of the left ventricular pressure. So the mean gradient increases enormously. So this is true severe AS because the valve area continues to be 0.6. Another example, ejection fraction is 25%, the gradient is only 25 millimeters of mercury, but the valve area is 0.6. Is it severe? Now this particular patient is having on dobutamine an improvement of the LV ejection fraction to 45%. As the LV pressure increases, the aortic pressure also increases. So the gradient only improves minimally. And the valve area also increases from 0.6 to 0.85. So this is pseudo-severe aortic stenosis. There is a sign that is described called the Paravalvar sign, which we all know. When we are pulling back the catheter across the stenotic aortic valve from the femoral artery into the ascending aorta, when the catheter moves from the aortic valve to above the ascending aorta, there is a sudden shoot up of the aortic pressure. Basic principle is like this. When we are pulling back a 7 French catheter, the 7 French catheter has got an external surface area of 0.05 square centimeter. If you are having an initial valve area of 0.6 square centimeter, the 7 French catheter with a 0.05 square centimeter is reducing the valve area from 0.6 to 0.55. Which means making it from critical to extra critical aortic stenosis. So there is a reduction in the aortic systolic pressure and the aortic pressure booms up by 10 millimeters of mercury if the catheter is pulled out. And that is the principle of Paravalvar sign. We briefly mentioned about this curve long ago. Valvulo-arterial impedance. The flow from the left ventricle into the aorta is created by an impedance at the valvar level and at the arterial level. So this is combined, this impedance is called valvulo-arterial impedance. So whenever there is a severe aortic stenosis, the LV pressure drops markedly. And we mentioned previously, the pressure recovery starts from the sinotubular junction in a small aorta so that the LV pressure regains. So this is actually the actual gradient that we will be getting by peak to peak gradient when we are doing the cardiac hemodynamics. But this is the gradient that we'll be getting on echocardiography during the peak instantaneous Doppler. We already mentioned about dilated aorta will have less of pressure recovery and a smaller aorta as seen in senile calcific aortic stenosis to have a better pressure recovery. So the indications of aortic valve replacement will be peak gradient of more than 64, mean gradient of more than 40 in a symptomatic patient. And we need to understand there will be few subgroups, low gradient, low flow, severe aortic stenosis where the ejection fraction will actually be low. They may have a contractile reserve, they may not have a contractile reserve depending on the response to dobutamine. And if they don't have a contractile reserve, in order to not make a decision purely based only on valve area by continuity wave equation, an additional criteria is given wherein the calcium score of more than 2000 in the CT scan is given a corollary, additional indication. The patient who is not having an adequate contractile reserve, if the patient is having substantial calcium in the aortic valve, we can assume that this aortic valve is going to be extremely rigid, and hence it's worth changing the valve. The last question is, what is this low gradient paradoxical severe aortic stenosis? A small proportion of patients with aortic stenosis will have progressive concentric left ventricular hypertrophy. Left ventricle does not dilate at all, and it keeps encroaching into the lumen due to progressive left ventricular hypertrophy, that the left ventricular end diastolic volume becomes smaller and smaller, and this restricts the flow into the left ventricle. So the left ventricular filling becomes highly compromised. So in such patients, the stroke volume becomes very low, and when the stroke volume is low, we know that the stroke volume is responsible for the aortic valve gradient, and so that is yet another indication, yet another subgroup of low gradient paradoxically severe aortic stenosis with the preserved ejection fraction. This particular patient will have extremely concentric left ventricular hypertrophy to compromise onto the lumen, thereby the left ventricular end diastolic volume and the left ventricular stroke volume both will proportionately reduce. During aortic valve replacement in catheter lab, when we are doing a rapid pacing, we are abolishing completely the aortic pressure curve. That means we are in fact causing lack of movement of the blood from left ventricle to the aorta, and this particular principle is used in the cardiac catheterization laboratory frequently whenever a particular valve or a balloon or a stent needs to be stabilized in a large blood vessel for a reasonable period till that balloon or stent is being fully deployed. Now coming to another trace wherein LV to aorta pull back, there is a fall in the pressure, however there is a fall in the left ventricular outflow itself. So this is an indicator that this is subvalvular aortic stenosis. So subvalvular aortic stenosis will have a drop in the left ventricular pressure from left ventricular body to left ventricular outflow. So this is an example of left ventricular body to left ventricular outflow, a pressure drop. So this is subvalvular LVOT narrowing. On the contrary, this is supravalvular LVOT narrowing. This is a left ventricular pressure which is 220 millimeters of mercury, and the ascending aorta is also 220 millimeters of mercury, and the aortic diastolic pressure is low. You continue to make a pull back, you will find that the ascending aorta before the stenosis is quite wide in its pulse pressure with extremely high systolic pressure and normal diastolic pressure. And when you pull back from the supravalvular aortic stenosis into the aorta beyond the supravalvular AS, you are finding that the aortic pressure is completely becoming normal. This, you need to identify that the aortic diastolic pressure is completely normal in a supravalvular aortic stenosis. This is different from pullback in a coarctation. In coarctation, the aortic diastolic pressure in the segment above the coarctation is high. It is not like the aortic diastolic, there is a true systemic hypertension with not only systolic pressure elevation but diastolic pressure elevation. So if you look at the true traces between supravalvular aortic stenosis and coarctation of aorta, in supravalvular aortic stenosis, the aortic diastolic pressure is normal, whereas in coarctation of aorta, the aortic diastolic pressure is high. The reason why it is so is The baroreceptors that are setting the level of the aortic pressure are located at the levels of aortic arch, carotid bodies, and they are distal to the level of supravalvular aortic stenosis. The lack of resetting of the baroreceptors will result in normal aortic diastolic pressure above the level of gradient. But in coarctation, the baroreceptors are reset. The region of baroreceptors in the aortic arch and in the carotid body are already facing higher pressures, and so the body resets the baroreceptor. The baroreceptor is reset that the aortic pressure is set at a higher level, and so there is diastolic hypertension. Coarctation is defined as a gradient of more than 20 millimeters of mercury at rest. And if you provoke them with exercise, it is more than 50 millimeters of mercury. What happens with provocation with exercise? Two factors. Number one, the cardiac output increases. So when there is a higher amount of flow through the same stenotic orifice, the gradient increases. Factor number two, the reason why the pressure gradient is only 20 millimeters of mercury between the ascending aorta to descending aorta is because of enormous amount of collaterals, and these collaterals are no longer sufficient when you are exercising with an increase in the cardiac output. So this results in the collaterals becoming inadequate, and hence you are getting an exaggeration of the gradient. So in other words, low gradient coarctation will happen whenever there is left ventricular dysfunction, whenever there is severe pulmonary hypertension in neonates where the forward cardiac output, when there is a high pulmonary vascular resistance, the forward drive of the cardiac output through the left atrium, left ventricle and ascending aorta reduces in these severely hypertensive neonates. So these patients may have low gradient. Whenever there is severe proximal mitral stenosis or aortic stenosis as in Schoen's syndrome, you will have severe coarctation. When you have PDA or collaterals, you may have low coarctation. When you have a coarctation and you put on anesthesia for a procedure, or if that particular patient is having a shock state or post-vasodilator drug, there may be low gradients. If the patient is having significant aortic regurgitation, again, that may be low gradients. The fact you should have a normal cardiac output to maintain a correct gradient. Heart rate. If the heart rate goes extremely low, the aortic diastolic pressure in the proximal segment also goes substantially low, and that will result in lack of diastolic pressure gradient. Collateral circulation is easy to understand. A fetal coarctation is without collateral circulation, so they precipitously have heart failure. Adult coarctation is with enormous collateral circulation, and so these patients do not have a substantial hemodynamic disturbance. PDA ampulla size. A wide PDA ampulla in the presence of a posterior aortic shelf will allow the blood to still go through. So PDA ampulla size will decide the severity of coarctation, and this is one of the reasons why in patients who are having critical coarctation in neonatal period, starting prostaglandin, even if they don't open the PDA but open only the aortic end of the ampulla, may result in reduction of the gradients and maintain them for some time. Length and shape of the obstruction, baroreceptor function, arterial wall compliance and vessel distensibility are the other factors. Factors like vessel distensibility are basically whenever aorta is being replaced by a foreign body like a PTFE patch aortoplasty or a Dacron patch aortoplasty, the altered vessel wall distensibility will also result in altered pressure tracing. Now we will go into left ventricular outflow tract obstruction at subvalvular level, wherein hemodynamics are of significance. Before understanding subvalvular aortic stenosis, let us assume what is valvular aortic stenosis. This is a patient with valvular aortic stenosis, LV trace and aortic trace. There is a substantial aortic stenosis gradient. There is an ectopic beat, and this is the post-ectopic post-ectopic beat. Post-ectopic beat is having a high LV systolic pressure. In a normal person, if there is an ectopic beat, that ectopic beat results in poor left ventricular stroke volume, and so left ventricular systolic pressure is low. In the compensatory pause that follows a long diastole, there is an acute autoregulation of the blood pressure which is caused by the sympathetic vascular tone, resulting in acute fall of the systemic vascular resistance. So the aortic diastolic pressure falls substantially in the post-ectopic beat. So when there is a next beat that is happening, the post-ectopic beat will start from a very low diastolic pressure to the same level of systolic pressure, thereby giving a high aortic pulse trace. So this is the reason why in a post-ectopic beat, if you feel the pulse, you will find a high pulse volume. The high pulse volume is caused by the systemic vascular resistance going down in the previous beat due to acute hemodynamic vasoregulation caused by sympathetic vascular tone. Because the systemic vascular resistance falls, in the subsequent beat when there is a larger LV stroke volume and the LV ejects this larger LV stroke volume, normally a higher LV stroke volume results in a higher aortic systolic pressure, but here it does not result in a higher LV systolic pressure because of previous compensatory fall in the systemic vascular resistance. So this allows an aortic runoff, and so we talked about valvulo-arterial impedance. The arterial impedance is very low, that the LV systolic pressure does not elevate in a normal heart, but in the presence of valvar aortic stenosis, there is a potentiation, the LV pressure goes high. So if you look at the pulse pressure in the basal trace and look at the pulse pressure in the post-ectopic beat, there is an increase in the post-ectopic beat. This is normal. This is preserved in valvar aortic stenosis also. However, what happens in hypertrophic cardiomyopathy? This is the LV pressure trace and the aortic pressure trace. This is the normal pulse pressure, but in the post-ectopic beat, the pulse pressure drops. Whenever there is an ectopic, there is a low LV stroke volume. This LV stroke volume being low triggers a lower systemic vascular resistance due to acute autoregulation and fall in the sympathetic vascular tone. So the lower systemic vascular resistance results in lower diastolic pressure. The next beat has got a compensatory higher left ventricular stroke volume. The higher left ventricular stroke volume results in higher Frank-Stallings law activation, resulting in extremely high LV contractility. This high LV contractility in the face of left ventricular outflow tract obstruction results in marked potentiation of the LV systolic pressure. In hypertrophic cardiomyopathy, the left ventricular outflow tract obstruction depends on two factors. Number one is the contractility. So when the contractility increased in the LV post-ectopic beat, the higher contractility resulted in higher left ventricular outflow tract obstruction, worsening the LVOT gradient. The factor number two that decides the left ventricular outflow tract obstruction is systemic vascular resistance. The lower the systemic vascular resistance, higher the gradient. So the acute fall in the systemic vascular resistance in the ectopic beat has resulted in fall in the systemic vascular resistance, which increases the left ventricular outflow tract obstruction. So combination of two factors, higher LV systolic contractility and fall in the systemic vascular resistance, both cause catastrophic elevation of the LV systolic pressure and fall in the aortic systolic pressure, thereby worsening this gradient, and this is what is called broken Brown-Wald phenomenon. When you look at the pressure trace from LV to aorta, pull back in a hypertrophic cardiomyopathy, left ventricle peaks in late systole in hypertrophic cardiomyopathy, because in late systole, the gradient becomes more and more severe with progressive LVOT obstruction. So this is a late systolic peaking. This left ventricle is not tolerating that. So the end diastolic pressure is going to 30 millimeters of mercury. In aorta, contrary to the anacrotic pulse that should be seen in an aortic stenosis, the initial LV stroke volume is transmitted onto a brisk ejection. So there is a spike in the aorta that is followed by a severe left ventricular outflow tract contractility that results in a sharp fall in mid-systole in the aortic pressure. So this is Bispherians pulse or bifid pulse. Continued LV ejection results in the dome pattern. So the second dome is caused by continued LV ejection. So the characteristic spike and dome is caused by a brisk ejection responsible for the initial systolic hike, and the later dome is caused by prolonged LV systolic contractility, and the mid-systolic notch is caused by a severe left ventricular outflow tract contractility. This is called as dynamic LVOTO. Reason why it is called dynamic LVOTO is because the LVOT gradient keeps fluctuating from time to time. You keep watching this pressure trace. The left ventricular outflow tract gradient is 2.5 squares, that is 50 millimeters of mercury here, and it is 70 millimeters of mercury here. It is 3.5 pressure, 3.5 squares. What actually happened between this and this? You are putting the patient in the cardiac catheterization laboratory and stretching the two arms across. The patient is not having the arm very stable, and so he continuously keeps the arm under some degree of contractility in order to maintain the position of his shoulders. And so there is some amount of isometric hand grip that is happening, which is increasing the systemic vascular resistance, and this increasing systemic vascular resistance is keeping the left ventricular outflow tract obstruction low. You give an arm support for the patient. So far, the patient was having an arm outstretched in the cardiac catheterization. Arm was not well supported, and so he was having an arm that was continuously kept in an isometric hand grip. Now he is relaxing because armrest has been given. The moment you give the armrest, this arm isometric contraction of the arm muscles reduces. That results in reduction of the systemic vascular resistance, and the reduction of the systemic vascular resistance results in increased contractility, and increased contractility leads to increased gradient. Look at the wave. Spike followed by dome. The dome is quite tall. Spike followed by the dome. Dome is quite short. So this is what is called dynamic LVOT obstruction. It will change from minute to minute, second to second. Broken-Brown-Wall defect we already saw. When there are 2 or 3 ectopics, the Broken-Brown-Wall phenomenon will become cumulative. If you have one ectopic and a post-ectopic beat, the aortic pressure drops, and then again an ectopic, and then a normal post-ectopic beat, again the pressure drops, so it becomes cumulative. So when there are a series of ectopics, this is not ventricular tachycardia, a series of ectopics, this patient goes into what is called a hypertrophic obstructive cardiomyopathy crisis, or in other words, syncope. Syncope in hypertrophic cardiomyopathy can be hemodynamic or arrhythmic, and we need to differentiate whether it is a hemodynamic syncope or an arrhythmic syncope in order to provide the correct type of treatment. For a person who is having an arrhythmic syncope, that means recurrent episodes of ventricular tachycardia, the treatment is different. For a person who is having isolated, repeated ventricular ectopics that are triggering a hemodynamic syncope, that other treatment will be catastrophic. Just putting in an intracardiac ICD and hoping that this patient's syncope will completely disappear, will not create any usefulness at all. So this is hemodynamic syncope. We also have to look at what is the back pressure. Left ventricular end diastolic pressure gets elevated, and as the LVEDP elevates, LA pressure also elevates, and so whenever there is a dynamic severe LVOT obstruction, this patient can develop severe left atrial pressure elevation, late systolic increase of the V waves caused by mitral regurgitation. This results in flash pulmonary edema. So as the severity of LVOT obstruction worsens, the MR is directly proportional to the LVOT obstruction. MR increases. More the LVOT obstruction, more the systolic anterior motion of anterior mitral leaflet. Higher the SAM, higher the MR, higher the MR, higher the LA pressure elevation, taller the V waves, and LA pressure will go up progressively high. So this is in short the hemodynamics of hypertrophic cardiomyopathy. Late peaking of LV systole, elevated LV end diastolic pressure, Broken-Brough wall defect due to post-ectopic potentiation. This makes the post-ectopic murmur becoming loud. LVOT gradient is dynamic, which means it is dependent on contractility and SVR from moment to moment, second to second. Aorta showing spike and dome pattern with a sharp early upstroke. Bifid pulse, the second peak is caused by continued ejection. LA pressure will show dynamic V waves and sharp Y descent. MR is directly proportional to the LVOT gradient and secondary pulmonary hypertension. These are the features that you will be getting in hypertrophic cardiomyopathy. Briefly touching aortic regurgitation. In acute aortic regurgitation, there is a wide pulse pressure. The dicrotic notch will go to very, very, very low levels. So this wide pulse pressure will cause a high systolic, low diastolic pressure and a low dicrotic notch. The high LV end diastolic pressure will lead to back pressure elevation, and this is LA pressure. LA pressure is showing tall V waves with LA mean pressure going progressively high. So acute AR resulting in significant pulmonary venous hypertension and pulmonary edema. Briefly going on to what is the effect of rhythm. Any rapid tachycardia will shorten the diastolic filling period and result in reduction of the stroke volume and reduction of the cardiac output. So a sustained ventricular tachycardia results in complete drop of the cardiac output, which resumes back to normal once the tachycardia is relieved. And this is basically the principle of rapid RV pacing in interventions that I mentioned earlier. So whenever there is a patient with severe aortic stenosis, in order to stabilize the balloon, this rapid ventricular pacing is adopted. We need to understand that pre-excitation, which results in an alteration of the ECG, does not actually cause a hemodynamic pressure difference. The aortic pressure will continue to be the same even in the presence of pre-excitation. Similar to ventricular tachyarrhythmia, atrial tachyarrhythmia also can alter the diastolic filling period and result in worsening of the cardiac output. A stable patient with mitral stenosis, when he gets a run of atrial fibrillation, there is a profound fall in the aortic pressures caused by rapid atrial tachyarrhythmia, which causes low diastolic filling and worsens the hemodynamic in mitral stenosis. Post-ectopic beat, we already explained. The normal post-ectopic beat in an aorta will have a wide pulse pressure. The reason why there is a wide pulse pressure is because the previous diastolic pressure goes very low, even though the systolic pressure remains the same. This wide pulse pressure results in brisk pulse, and so a high volume pulse is appreciated on pulse examination in post-ectopic beat. In the normal heart, the left ventricle does not have a post-ectopic potentiation. The reason being, even though there is a higher LV stroke volume caused by the longer diastolic time, the higher LV stroke volume is compensated by a fall in the systemic vascular resistance due to acute hemodynamic autoregulation of the sympathetic vascular tone, and that results in valvulo-arterial impedance to go low, so the left ventricle does not rise its pressure. On the contrary, in the pulmonary side, the pulmonary vascular resistance is already very low. So in a post-ectopic beat, there is no further drop in the pulmonary vascular resistance when there is a long diastole. So the next beat where there is a higher RV stroke volume is going to reflect as higher RV systolic pressure and higher PA systolic pressure in the post-ectopic beat, that is caused by a lack of significant fall in the pulmonary vascular resistance in the post-ectopic beat. Post-ectopic potentiation in the left ventricle happens only when there is aortic stenosis. Aortic stenosis can be fixed or dynamic. So this is post-ectopic potentiation in a hypertrophic cardiomyopathy that is caused. This is a characteristic feature of LV outflow tract obstruction. To summarize, post-ectopic aorta, the pulse pressure widens. There is a bounding pulse, but the systolic pressure is the same. In LV, the systolic pressure is the same and there is no potentiation. In RV, the systolic pressure increases and there is a potentiation. Whenever there is left ventricular outflow tract obstruction, LV systolic pressure increases and there is a potentiation. Whenever there is a dynamic LVOTO, as in hypertrophic cardiomyopathy, not only there is an LV systolic pressure potentiation, but also an aortic pressure drop, thereby worsening the gradient. Whenever the right ventricle is supporting the aorta, as in tetralogy of Fallot or in VSD Eisenmenger syndrome, similarly in transposition, uncorrected transposition, there will not be any RV potentiation. The last hemodynamic trace for discussion, which many of the postgraduate students wish to hear. Right atrial pressure curve shows mean pressure is elevated at around 25 millimeters of mercury with a sharp Y descent. No inspiratory and expiratory variations. Lack of inspiratory fall in the RA pressure, which is defined as Kussmaul sign. Kussmaul sign. The normal inspiratory reduction in the intrathoracic pressure in a normal heart is transmitted to the intracardiac pressure, and so there is a normal fall in the intracardiac pressures in all the chambers. RA, RV, LA, LV, all chambers will have a reduction of the pressure traced in inspiration. Kussmaul sign is caused by shielding of the heart by a constricted rigid pericardium. So the intrathoracic pressure fails to be transmitted into the intracardiac pressure. So the intracardiac pressure is now immune for the fall in the intrathoracic pressure which is happening outside. So lack of inspiratory fall of RA pressure is Kussmaul sign. I want the concept to be very clear. During normal inspiration, in all of us normal people, 3 hemodynamic changes occur. Number 1, fall in intrathoracic pressure results in fall in intracardiac pressure, results in fall in intracardiac all the pressure traces. 2, reduction in the intrathoracic pressure during inspiration sucks in the blood from superior and inferior vena cava, leading to enhanced RA filling, enhanced RV filling. RV now contracts better due to Frank-Starling's law activation. RV ejection is exaggerated. So there is an improved RV filling. I mentioned RV pressure reduces in intrathoracic pressure. When intrathoracic pressure reduces in inspiration, RV systolic pressure also reduces. It's true, RV systolic pressure increases, but flow increases. Flow is high in RV systolic pressure, RV outflow tract, and that is the reason Carvalho sign is positive. Whenever there is an inspiration, there is an augmentation of all the right ventricular events during inspiration. Right ventricular ejection increases, right ventricular contractility improves, right ventricular stroke volume increases, but RV pressure reduces. RV pressure reduction does not mean RV flow is reducing. Flow is increasing, pressure is reducing. The third phenomenon that happens is pulmonary artery capacitance increases. The reduction in the intrathoracic pressure stretches out the pulmonary vasculature, resulting in increased pulmonary artery capacitance. So the pulmonary artery now accepts a higher volume inside. So there is a higher pulmonary artery, antegrade pulmonary blood flow. The same increased RV contractility and increased pulmonary blood flow also happens in constrictive pericarditis. So if you put the tricuspid valve Doppler, the tricuspid valve Doppler will show a higher velocities in inspiration, and pulmonary artery systolic Doppler, the pulmonary artery Doppler will have higher velocities in inspiration in constrictive pericarditis. But RA pressure does not fall. So when I say that Kussmaul sign is positive, which means lack of inspiratory reduction in the RA pressure, I am not telling antegrade blood flow through the right side of the heart is reduced. Flow is increased, flow is preserved, but pressure is not transmitted. So when the pressure is not transmitted into the right atrium, the right atrial pressure remains the same, it does not fall. It's very important to understand this, because when I'm going to talk about RV systolic pressure, I will introduce more concepts. Now come to prominent Y descent. The right atrium pressure falls whenever there is a tricuspid valve opening. So the RA mean pressure is very high. Suddenly it drops when the tricuspid valve opens, and so this results in a fall in the right atrial pressure. So Y descent is the characteristic hallmark of constrictive pericarditis, which is also called Frederick sign. Now if you carefully look at the A and B wave, I mentioned RA will have a higher A wave and a lower B wave because B waves are dependent on the compliance of the ventricle. Right atrium being a better compliant atria, right atrium has got a large free wall and a large right atrial appendage, so it accommodates, so V wave is low. However, in constrictive pericarditis, a rigid cavity, RA's compliance becomes slow because the pericardial compliance is not allowing the RA to become more compliant. So this results in RA, A and B becoming equal, and this gives what is called as the M pattern. The deep Y descent is correlated by the steep filling of the ventricle only when the tricuspid valve opens. So there is an abrupt fall in the RA pressure during the Y wave, and that is the reason why Y descent is very steep. Look at the left ventricular pressure trace. The left ventricle also has got the rapid filling, which means the entire ventricle now is rapidly filling in the early diastole, but immediately the filling is restrained by the rigid pericardium, and so there is a marked elevation of the mid and late diastolic pressures, resulting in dip and square root pattern. End diastolic pressure gets elevated. Right ventricular end diastolic pressure also gets elevated for the same same reason. Both the filling of the ventricle across left and right ventricle happens only during early diastole, and during late diastole there is no filling at all. And so mid and late diastole there is a dip and square root pattern. Since the pathology is equally affecting the right and the left ventricle, both simultaneously increase and both the end diastolic pressures are symmetrically elevated. So when you compare left ventricle and right ventricular end diastolic pressures, the difference is not much. Both of them are more or less the same. The difference between left ventricular end diastolic pressure and right ventricular end diastolic pressure taken at the peak of the R wave remain more or less the same, within 5 millimeters of mercury. Why the RV pressure does not get elevated? Since constrictive pericarditis equally affects the right and the left ventricle, the forward flows in the right ventricle and pulmonary artery pressures are low, that the pulmonary artery pressure does not go very high. In other words, the entire cardiac output is low so that elevated LA pressure that is happening due to restriction of the heart is not getting transmitted onto the pulmonary artery because antegrade forward flow itself is low. This is something like, for example, what you see in critical mitral stenosis, very severe mitral stenosis, who are having very severe pulmonary arterial hypertension, and those when the very severe pulmonary arterial hypertension is there, the mitral stenosis sort of becomes silent. Something similar to that. In a patient who is having a forward antegrade flow is very low, as in these patients where the right ventricular filling is low, the PA pressure does not elevate high. So the PA pressure continues to remain minimally elevated and the RV systolic pressure minimally elevated. Look at the pulmonary artery wedge pressure. The X and Y descents are quite prominent. Y descent is much more prominent. If you carefully look at Y descent, then normally the Y descent should happen at the level of end of the systole and early diastole. But this is much later because of the phase delay. Pulmonary artery wedge pressure has got a phase delay from the LA pressure. So it is much later, but this is the Y wave. So the Y descent is very prominent. So the hemodynamics of an hemodynamics of a constrictive pericarditis is RA mean equal to RVED equal to PA diastolic pressure equal to PA wedge pressure equal to LVED, all within 5 millimeters of mercury. Now there is a question. In constrictive pericarditis, intrathoracic pressure is not transmitted to cardiac chambers and hence we get too small. But why is flow increased in tricuspid valve during inspiration? Exactly, I mentioned the same thing. I'll again go back. In a normal person, the inspiratory fall in the intrathoracic pressure also makes a fall in the intracardiac pressure, so the RA pressure falls. But the flow increases. The reason why the flow increases is because of augmented systemic venous return, increasing the RV cardiac output. Higher amount of stroke, higher amount of venous filling of the RV causing better RV stroke volume due to Frank-Starling's law. So the RV ejection is increased. A low afterload for the RV due to improved pulmonary artery capacitance, so better pulmonary artery filling. All these are causing a higher pulmonary artery blood flow. That is what is causing the Carvalho sign to be positive. All right-sided events during inspiration are getting aggravated, but pressures in the right atrium and right ventricle fall. Flow increases, but pressure falls. Now, in constrictive pericarditis, RA is shielded. RA pressure does not fall. RA pressure is not reducing with inspiration. But the other phenomenon that I told continues. An increase in the a fall in the intrathoracic pressure that sucks the blood from the superior and inferior vena cava into the right atrium, continues to fill the right atrium, continues to fill the right ventricle. The right ventricle gets a better stroke volume, right ventricle ejects better, right ventricle fills the pulmonary artery better. But because it is a rigid pericardial cavity, this right ventricular higher filling is at the cost of left ventricle, which is called exaggerated ventricular dependence or ventricular interdependence, and I'm going to come to it in the next slide. So flow is maintained. Right ventricular higher flow is maintained during inspiration. Right atrial pressure drop is not happening. Kussmaul sign is failure of right atrial pressure drop. Increased flow in inspiration is maintained. That is the reason tricuspid valve flow Doppler is exaggerated in inspiration. It is at the cost of exaggerated ventricular interdependence hitting the mitral valve, so mitral valve will proportionately go low. Now I am coming to in constrictive pericarditis. When you put in the catheter into the aorta, since the systemic vascular resistance is high, it is causing a dicrotic pulse with elevated diastolic pressure. When you take an LV to aorta pullback in a constrictive pericarditis, the high LV end diastolic pressure, the dip and square root pattern, and in the aorta there is a high dicrotic pulse caused by high systemic vascular resistance. So to summarize, constrictive pericarditis, high right atrial pressure caused by the restriction. A becomes equal to B because right atrial compliance reduces secondary to entire pericardial compliance reduction. Y descent is prominent because RA pressure reduces only when the tricuspid valve opens. RA pressure is so high that it drops down only when the tricuspid valve opens. So Y descents are very prominent. Frederick sign. Kussmaul sign, there is no effect on intrathoracic pressure on the heart. Intrathoracic pressure and intracardiac pressure are separated. RV and PA pressure do not elevate much because of the lower cardiac output. There is not much of RV and PA flows to cause a higher PA pressure that is seen often in restrictive cardiomyopathy. LVED and RVED elevate due to restricted filling, and both are matching. Filling of the ventricle is confined to early diastole, causing dip and square root. Already we mentioned RA mean, RVED, PA diastolic, PA wedge mean, LVED, all are within 5 millimeters of mercury. The increasing venous return during inspiration has to be accommodated by the right-sided cardiac chambers at the cost of left-sided cardiac chamber due to enhanced ventricular interdependence, thereby at the cost of mitral flows. Coming to right-sided pathology, coming to restrictive cardiomyopathy. Again, restrictive cardiomyopathy has got the same phenomenon. However, the Y descent is not so deep. Since these patients have got a higher pulmonary artery pressure, A wave is taller. M pattern, A being equal to V is constrictive pericarditis. A will still continue to be taller in restrictive cardiomyopathy. Since restrictive cardiomyopathy is primarily a left ventricular pathology, right ventricle is less affected, and so right ventricle continues to pump effectively against the high LA pressure. So in spite of the LA pressure being high, there is a post-capillary pulmonary hypertension and RV pressure gets elevated higher and higher. RV EDP increases, but much more than the RV EDP, LV EDP is further elevated. I'm getting a feature that my voice is not clear. Is it poor?
No, sir, it's fine. It's going fine.
Thank you. So the RV systolic pressure is much more elevated in restrictive cardiomyopathy than in constrictive pericarditis because right ventricle is less affected, which makes the right ventricle continues to pump the cardiac output into the pulmonary artery till late stages when the true cardiac output falls, and hence these patients have a higher pulmonary hypertension and right ventricle systolic pressures. So when the right ventricle systolic pressure goes very high and the right ventricular end diastolic pressure proportionately is slightly lower, RV EDP to RV systolic pressure ratio is less than 1. Since the pathology is primarily involving the left ventricular end diastolic pressure disproportionately goes up. So LVED RVED ratio, LVED is much higher than the RVED. The pulmonary artery pressure also elevates, as I told in the earlier slide. So the PA systolic pressure is almost touching 65 millimeters of mercury. Pulmonary capillary wedge pressure is much higher than the RA pressure because pulmonary capillary wedge pressure is reflective of the LA pressure. But contrary to CP, the very deep Y waves are not so characteristic in restrictive cardiomyopathy. So summarize. Constrictive pericarditis will have almost equal LVED, RVED. Usually pulmonary hypertension is not severe. And because the pulmonary hypertension is not severe and RV systolic pressure elevation is less, RVED is proportionately much higher than the RV systolic pressure. In restrictive cardiomyopathy, LVED is much higher than RVED because LV is the primary ventricle getting involved. Since the right ventricle is not involved much, right ventricle continues to pump effectively, thereby leading on to pulmonary hypertension, and so the pulmonary artery pressure increases. The right ventricular end diastolic pressure is not so severely elevated like the LVEDP, so the RVED to RV systolic pressure ratio remains less than 1/3. This is what is called as the systolic area ratio. Carefully look at this trace. Right ventricular pressure increases during inspiration. Now, CP breaks the rule that all intrathoracic pressure reduce on inspiration. Intrathoracic pressure fall in inspiration should result in fall in the intracardiac pressure in all the chambers. We already mentioned in right atrium it does not reduce, it is maintained the same because it is shielded from the intrathoracic pressure. What happens to the right ventricle? There is an inspiratory increased venous return from superior and inferior vena cava into the right atrium, and this right atrium transmits that higher inspiratory venous return into the right ventricle. So the right ventricle gets a higher venous return, higher ventricular filling in diastole. This activates the right ventricular stroke volume, and so the right ventricle now ejects with higher pressure, higher stroke volume, resulting in better RV ejection. That is the reason why when tricuspid valve Doppler and pulmonary valve Doppler increases even in CP. But then why there is a RV pressure elevation? There is a higher stroke volume that is happening in the right ventricle, so the right ventricle fills better, but it is at the cost of exaggerated ventricular interdependence. The ventricular septum is pushed towards the left ventricle and LV underfills. So RV better filling in inspiration is at the cost of LV underfilling in constrictive pericarditis during inspiration. So the RV fills better, it ejects a higher stroke volume, which results in RV systolic pressure elevation, because whenever there is an increase in the systolic stroke volume, there is an increase in the systolic pressure that does not happen in a normal person because of fall in the RV systolic pressure that happened due to transmission of the intrathoracic pressure on the intracardiac pressure. Now the RV is also shielded. So the RV pressure increases. So CP breaks the rule that all intrathoracic pressure reduces on inspiration. RV systolic pressure actually increases in constrictive pericarditis. So this results in RV pressure going higher at the cost of LV pressure going lower. So the systolic pressure ratio between the RV and LV markedly reduces in inspiration and widens during expiration. So this is the explanation for the systolic area ratio between the two. So now to again re-summarize, restrictive cardiomyopathy in atria will have less prominent Y descent, more prominent A wave because pulmonary hypertension is there. It will have normal respiratory variation, so that means inspiratory fall. In ventricle, uniformly both the ventricles will have square root sign. RV systolic pressure will be high in restrictive cardiomyopathy. RV-ED to RV systolic pressure ratio difference and LV to RV ED ratio we have already told. The interdependence is minimal. Pulmonary artery wedge pressure trace also shows less prominent Y descent compared to constrictive pericarditis. Normally, whenever there is a deep inspiration, the blood gets pooled within the lungs and the amount of filling of the LA and LV is low. In all normal people, during inspiration, when the intrathoracic pressure falls and the lungs expand better, the pulmonary arterioles, capillaries, vein all hold more amount of blood. So the pulmonary venous return in inspiration is low in all normal people. So this results in reduction in the amount of mitral filling and aortic filling in inspiration in all normal people to a minor degree. In constrictive pericarditis, the same intrathoracic pressure reduction during the inspiration results in pooling of the blood within the lungs and results in blood not going into the left atrium and left ventricle. So this results in the left atrium and left ventricle, since they are guarded within a high pressure chamber by the rigid pericardium, left atrium and left atrial ventricular pressure will slightly be higher, but the pulmonary capillary pressures will be much lower because intrathoracic pressure is able to influence the pulmonary vasculature. So if you look at the pulmonary capillary wedge pressure, it will fall much more lower. I will show the example in constrictive pericarditis. During inspiration, the pulmonary capillary wedge pressure will go much lower than even the left atrial pressure, that hardly there is any filling on the left side. Left side blood does not enter at all. So the mitral valve flow Doppler will show markedly reduced inflow velocities. The reason is pooling of the blood in the lungs, pooling of the blood in the pulmonary vasculature, because the negative intrathoracic pressure is able to act on the pulmonary vasculature and pool the blood there. Left atrium and left ventricle being shielded, their pressure is higher. So there is a reverse gradient. The reverse gradient goes, the pulmonary capillary wedge pressure will go actually below the left atrial pressure in constrictive pericarditis. So that is the reason why there is a marked reduction in the mitral inflow. So summarizing, in constrictive pericarditis, equal A and B, very prominent X and Y descents, M pattern, Kussmaul sign. In the ventricle, square root sign, all these we already defined. And in the pulmonary capillary wedge pressure to ventricle, there is a variation in early pulmonary capillary wedge to LV gradient. Pulmonary capillary wedge will go negative than the LA pressure and LV pressure during inspiration. Last point about rapid filling wave. Rapid filling wave is the early dip diastole. The dip diastole is powerfully present in both the restrictive physiologies. Much sharper in constrictive pericarditis and less sharper in restrictive cardiomyopathy. So a rapid filling wave of more than 7 millimeters of mercury, much sharper rapid filling wave, is a feature of constrictive pericarditis, and rapid filling wave is not so sharp in restrictive cardiomyopathy. So this is the same summary. Cardiac tamponade is the last we are going to wind up. Cardiac tamponade is caused by a very high amount of fluid in the pericardium, which is pressing on the cardiac structures. Since the left ventricular filling is low, there is a low blood pressure. There is a very high level of ventricular interdependence. When there is a large amount of fluid that is pressing the heart, an inspiratory augmentation of the venous return from the superior and inferior vena cava into the right atrium is transmitted to the right ventricle. This right ventricle will be able to accept this higher stroke volume only at the cost of reducing the left ventricular filling. So there is an exaggerated ventricular interdependence. Much higher than the exaggerated ventricular interdependence that we saw in constrictive pericarditis. That it is even seen as pulsus paradoxus in the aortic outflow. So there is a low aortic pulse pressure and a low aortic systolic pressure in inspiration and a high pressure in expiration. Overall low volume pulses and high central venous pressures. X descent is prominent. Why? When there is a lot of water that is surrounding the heart and pressing the heart, the right atrium empties well only when the tricuspid valve ring is pulled towards the right ventricle. Basically, what is happening? There is a stretch of the right atrium. The atria is stretched to a large diameter by the right ventricular pull of the tricuspid annulus towards the ventricular apex. So the right atrium is stretched out. When all the entire heart is surrounded by a high amount of fluid, the only time when the ventricle, when the atria will drop its pressure will be when the atria is getting stretched. It does not happen. Why is not prominent? Why? During early diastole in constrictive pericarditis, there is a sudden rapid ventricular filling. In constrictive pericarditis, the only time when the ventricle fills is in deep diastole or early diastole. So there is a sudden filling of the right ventricle during early diastole, causing a marked fall in the RA pressure, so sharp widening. The same does not happen here because RV is externally compressed by the high fluid. The surrounding pericardial fluid is not only pressing the RA but also pressing the RV. So RV is also being pressed. So when the tricuspid valve opens and the right ventricle has to fill, RV is not filling. RV is collapsed. RV is collapsed by the surrounding high pericardial pressure which is squeezing the RV. RV cannot fill. Early diastolic filling that happens in constrictive pericarditis does not happen in cardiac tamponade. So Y is not proper, but X is proper. So this is the characteristic feature of cardiac tamponade. Understand ventricular interdependence. Distension of one ventricle affects the filling of the next ventricle. This is called ventricular interdependence. In inspiration, all the events on the left side becomes less. LV stroke volume is low. Aortic pressure is low. Pulse pressure is low. LV ejection time is low. Q to A2 interval is low. Mitral inflow velocities are low. All are low, but to a very minimal degree that they are not perceived by our routine Dopplers and routine clinical examinations. The same thing vice versa in expiration. all these parameters increase on expiration. We don't appreciate it because the amount of variation is very small. The normal 3 to 6 centimeters of water variation that happens in intrathoracic pressure between inspiration and expiration transmits as 3 to 4 millimeters of mercury onto the intracardiac chambers, and this 3 to 4 millimeters of mercury change on the left side is not perceivable for clinical examination and Doppler. In cardiac tamponade, the added findings, it is markedly exaggerated, so you get all these aggravated. The IVC congestion, RA collapse and RB collapse on echocardiography are indicator of tamponade. RA pressure becomes equal to pericardial pressure. Because the RA pressure becomes equal to pericardial pressure, the pericardium is able to compress the right atrium and right ventricle and prevent the right ventricular filling. So, we have today discussed pulmonary arteries, aorta, various forms of left ventricular outflow tract obstructions, the various changes that happen with rhythm changes, and finally, the commonly asked questions in the examinations like discussion of hemodynamics in restrictive cardiomyopathy, constrictive pericarditis, cardiac tamponade, and hypertrophic cardiomyopathy. I would say, understanding the hemodynamic traces basically improves your concepts in cardiology in clinical decision making. I have shared my phone number and my email address for any questions that you may get, and we will be able to reply it. As pointed out earlier, the next session will be on oximetry, calculation of cardiac outputs, shunt assessments, and operability decision making. We will do it around 3 days later, so that this next 3 days will act as an impetus for us to just consolidate what we have learned in this last 24 hours. So I would like to thank each one of you for staying patient and listening.
So can I close the meeting, sir?